Namaste, friends. I am Dr. Chandan Sarmah, Senior Medicine Specialist and Diabetologist from Tinsukia, Assam. So I'll be discussing on a new case, a newly diagnosed type 2 diabetic patients with high baseline HbA1c level. Mr. AB, 45 years old, will newly diagnosed with type 2 diabetes, visited my clinic 6 months back with multiple risk factors like obesity, hypertension, and hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. Recently, he again visited me as part of a routine checkup. His lab workup showed the following reports. HbA1c was 8.5%, eGFR was around 80 ml per minute per 1.73 meters square. His LDL cholesterol was 80 milligram per deciliter, HDL cholesterol was 38 milligram per deciliter, and a triglyceride was 200 milligram per deciliter. Medications, he was on metformin 1000 milligram BID, lisinopril 40 milligram once daily, metoprolol extended release 100 milligram once daily, atorvastatin 40 milligram, one tablet at bedtime, aspirin 75 milligram, one tablet at bedtime. On physical examination, his BMI was 31 kilogram per meter square. His blood pressure was 120 by 70 millimeter of mercury, and his heart rate was 78 beats per minute. Now, evidence indicates that early intervention as well as achievement of glycemic control reduces the long-term risk of microvascular as well as macrovascular complications, in particularly type 2 diabetic patients. UKPDS has demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10 years post-trial was apparent, even though there was no difference in the HbA1c levels between the intensive as well as the conventional therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, an initial combination therapy could be also considered to achieve a target more quickly, particularly in the patients with high baseline HbA1c levels. Early combination therapy in type 2 diabetic patients makes clinical sense for several reasons. First, a meta-analysis have demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c of less than 7% compared with metformin monotherapy. Now, for patients with HbA1c more than 1.5% above the goal at diagnosis, American Diabetic Association and European Association of Study for Diabetes guidelines recommend first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular disease, congestive heart failure, or chronic kidney disease. Empagliflozin and linagliptin combination makes a complementary mechanism and pleiotropic benefits have been shown, and this combination could be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or at high risk of cardiovascular disease, established heart failure, or chronic kidney disease due to the tolerability of this combination, in addition to the potential benefits of empagliflozin on cardiovascular as well as renal outcomes, and no increased risk of heart failure with either of these agents. According to a study, in fact, early achievement of A1C less than 7% with this combination of EMPA and LINA could reach a target HbA1c at 12 weeks compared to monotherapies. HbA1c decrements by the combination of empagliflozin and linagliptin in a dose of 25 and 5 milligram has demonstrated a 1.81% HbA1c reduction at HbA1c baseline of more than 8.5% at 24 weeks in the metformin treated group. And the benefits of glycemic control of this combination were maintained at week 52 in metformin treated groups, and a higher percentage of patients achieved HbA1c of less than 7%. And these were reported with these combinations. Now, the combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia, as well as weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP-4 inhibitor has been added, perhaps because of a better glucose control, although other possible mechanisms remains to be investigated. In summary, this combination of empagliflozin and linagliptin combination provides robust HbA1c reduction of around 1.8% and a 2 to 4 times higher odds of patients reaching the goal of HbA1c compared to the individual agents with low hypoglycemic risk. And lastly, this combination of these agents have been associated with a lower incidence of genital infections that are commonly seen with monotherapies with SGLT2 inhibitors. Thank you everyone for your patient hearing.